So, hello, Dr. Kublin. How are you today?
Hello, Guinevere. I'm fine, thanks. How are you?
I'm good. So, you graduated from Marquette Senior High School, correct?
I did.
Awesome.
Yes.
Do you have any memories from MSHS that you'd like to share? Or just good time?
That I'd like to share?
Yeah.
Well, there are quite a few memories. Most of them fondly. I think of my time there with great fondness, actually. I have still very good friends from that period of time. And, you know, it's a very formidable period of one's life. And you know, I think that I'm looking at what looks to be maybe, you know, in the quad area or the pod, and someone popped on with lockers in the background. It looks like they've gotten a new paint job since I was there. You know, my fondness goes also to some of the great teachers I had there, and some of whom I've kept in touch with, some of whom have passed away, and introduced me to good literature, and of course the sciences, which is, you know, what I'm so passionate about, and remain interested in being a curious student, you know, ever since, and continue to consider myself a student of this great world we're in. So those are a few reflections.
Yeah, well, that was awesome. So how did you get to where you are today from Marquette, or like just your college experiences?
Well, yeah, no, that's quite a long and nonlinear path. I think many people end up being a doctor, a physician, right out of the gate from high school, and I did not follow that path. I pursued a liberal arts education at Georgetown University. I was an undeclared major at first in the School of Business, actually, and had an interest in international marketing, believe it or not. But I dropped out of college after 2 years and spent a year in Central America, essentially as a village healthcare worker. And that really, both literally and figuratively, you know, gave me the bug of infectious diseases, and have been pursuing it ever since.
Awesome. So what are some important things that you've learned in your line of work, or just along the way?
Important things I've learned in my line of work?
Yeah, or just, yeah.
Well, I think, you know, I've had a very fortunate and rich professional career so far that has taken me to many different international settings. I've worked and lived in communities of refugees in Southeast Asia and Central America. I've lived for several years in Sub-Saharan Africa, and have traveled extensively. And I think that that exposure to so many different cultures and experiences has taught me an appreciation for the diversity and wonderful diversity that exists in the world, and that at the same time, and as diverse as we all are, there's some tremendous similarities that we're all looking for.
For sure. Well, speaking of the pandemic, you're working on a COVID vaccination, correct?
Right. I'm helping run an organization that is testing the efficacy of many different vaccines. We currently have 5 vaccines that we're evaluating. These are the 5 main vaccines that the U.S. government is funding and supporting, and that's across a number of different platforms of vaccines. There's nucleic acid vaccines and viral vector vaccines, and protein vaccines. And so we're helping actually 6 large efficacy trials. We just finished enrolling in Moderna vaccine trial last week, and the Pfizer vaccine trial will be completed hopefully in the next week or 2, and then we'll have 4 more vaccine trials to complete.
That's awesome. How does the process of creating a vaccine start?
I'm sorry, could you repeat that?
Yeah. How does the process of creating a new vaccine start? How do you go about that?
Oh, the process of a new vaccine is, historically one that typically takes years. There's a young student that Abigail has. He's really quite beautiful. He's received vaccines, I hope, and the vaccines that most of us have received have taken sometimes decades to develop. But in the current environment, and with the resources and billions of dollars that have been leveraged and invested in these vaccines, we have a portfolio of different vaccines that require very different strategies to develop. These nucleic acid vaccines, the mRNA vaccines by Pfizer and Moderna, are the most rapidly developed because they're the ones that are using the most advanced modern technology to create these vaccines. And so they're also the ones that are least tested in humans. So we're very excited to see the results of these nucleic acid vaccine strategies, and there's a lot of hope that they'll result in being both safe and effective. And for some of the other vaccine strategies, it takes a little longer, sometimes months, sometimes perhaps even more than a year from when the initial strategy is defined. But even a year is remarkably accelerated to begin testing a vaccine in humans from when you first identify the pathogen that you're trying to develop a vaccine against. So these vaccines are tested in phase 1, phase 2, and phase 3 clinical trials. Phase 1 studies are usually in just double digits number of people. Phase 2 studies are usually in the hundreds of people. And then phase 3 studies are these studies that will really assess whether or not a vaccine is effective. Phase 3 are efficacy trials. And these are the big studies that I'm involved with. And it requires 30 to 60,000 people in each of these 6 vaccine trials that we're involved with.
Now that we have kind of the bases across, I'm going to open up questions to anybody who's in the Zoom or in the classroom. So if anybody would like to unmute if they have a question, or send it in the chat and I can ask it.
I have a question. So, we know that people can get COVID multiple times. So does that mean, how often would people have to get a vaccine?
Oh, that's a great question, Abby. And indeed, it is clear that some people may be infected with SARS-CoV-2. It isn't clear what the clinical follow-up is of those individuals. We're hoping that when you're reinfected with SARS-CoV-2, that the clinical symptoms and the disease itself will be much milder, and that some of the pre-existing immune responses to the first infection will be boosted by that subsequent infection and reduce both the severity of disease and the likelihood of that person transmitting to another person. So those are the 2 main things that we're looking at in these vaccine studies. Of course, other than safety, is preventing severe disease, but also assessing whether or not it reduces the transmission of SARS-CoV-2. Reinfection is a major focus of a lot of attention right now, because it does indicate that if you're reinfected, your immune system did not develop a protective response, which means that the durability of the protective response after that first infection may have waned and may be decreasing. So that tells us that if we're inducing similar responses with a vaccine, perhaps a vaccine is not going to be providing durable protection. So that is a major focus of our efforts in understanding. First, of course, we need to confirm that these vaccines are working to either reduce disease or infectiousness. Then we'll be focusing also on the durability of that protection. There are a number of different ways that individual vaccines can be enhanced so that the durability is improved, and that's something that's called adjuvants. And the adjuvant is given to a vaccine to help boost the immune response and improve its durability. And there are many different adjuvants, and it's actually a very exciting and fascinating area of biology and immunology. On the other hand, there are precedents for requiring repeated injections for maintaining protection against an infectious disease. And of course, the most common one of these is flu, where we have annual flu vaccines. And that's a result of a combination of both the waning durability of those protective responses, but also the complexity and the variation of the strains of flu that circulate around the world and that cause influenza. So it's a fascinating question, and one that is going to be the focus of a lot of attention in the coming year.
Thank you. And Ava asked a question in the chat, and she was wondering, how long have you been working on the vaccine?
So I started working on this around March, and we have a facility here in Seattle with the Kaiser Hospital Network. It's a research foundation that's part of Kaiser, the Kaiser Network. And we started the first phase 1 study of the Moderna mRNA vaccine here in Seattle in March, which is a remarkable feat to be able to obtain the sequence of the virus in January and start a vaccine trial in March. And so that was a fantastic undertaking, and provided the preliminary safety and immunogenicity data. And immunogenicity data is the measurement of how well the vaccine induces an immune response in people. It provided that data to support moving forward into phase 2 and phase 3 testing. And then we've been busy ever since. I see the next question from Maverick. Can the vaccine be injected through a nasal spray for younger people? That's also a great question. Some vaccines have been delivered via nasal spray, such as flu mist. None of the vaccines currently being tested are using the nasal spray strategy, but it is one that is being considered and is very relevant to SARS-CoV-2 infection, because coronavirus really does populate the nasopharynx and the nose and the sinuses. And that's where the bulk of the replication seems to be occurring with this virus, although it can replicate in many other tissues throughout the body. Let's see, Kenneth also has a question. What vaccine do you think will be completed first? So the Moderna vaccine is the first one to complete its full enrollment into a phase 3 efficacy trial in the United States. That said, the Moderna study, and they completed enrolling, and we contributed to that last Thursday with 30,000 people. And the Pfizer vaccine is very similar to Moderna, and they have approximately 39 or 40,000 people enrolled in their clinical trial. Their target enrollment is 44,000, and they should be finishing in the next week or two. And so those are the two developers that are in the lead right now. But there are other strategies using what are called viral vectors, that are little viruses that deliver a piece of the coronavirus. And there are two platforms, two developers focused on viral vectors. One is AstraZeneca using a chimp adeno vector, and the other is Janssen & Johnson, which is using a adenovirus vector. And let's see, from Rhonda Mannanen, just like paying taxes is for the greater good, can you talk about how getting a vaccine is for the greater good? And this is a great topic of discussion for us within the field right now. Because there are a lot of commercial interests currently that are competing in this landscape. And much of the effort that's currently underway in the US is being funded by taxes. And so these taxes that people are paying are going to an incredibly beneficial cause for society. And that is to, of course, control and hopefully eventually eradicates SARS-CoV-2. And vaccines as well, all of the different licensed vaccines provide a tremendous amount of good to society and communities in general. And the approval for vaccines takes all of that into consideration, and is a major focus of why vaccine hesitancy and some of the anti-vaccine movements need to rely on evidence as much as possible. And much of the, if not all of the evidence that I've seen by these anti-vax groups has really been disputed and not substantiated by the science. So there's a bunch of great questions. Let me keep moving down this list. Jason, how will we be able to keep up with new mutations of COVID-19 since it is an RNA virus? That's a great question. Fortunately, it's not as fast of a mutator as flu, but it may indeed require a next generation of vaccines. And that largely depends on the frequency of mutations that occurs with SARS-CoV-2 and how that evolves. And I'd highly recommend you visit Trevor Bedford's lab site, Bedford Lab. If you Google that, you'll find it. He's a friend and colleague right here in Seattle, who's doing the most advanced work globally on both flu and SARS-CoV-2 phylogenetic analyses, assessing the mutation of these different viruses. Ava also has a question. Kayla, what got you into making vaccines? So I contracted malaria when I was 21 years old, and if you really want to see something like that's out of this world from a sci-fi alien type of movie, look at the malaria life cycle. Just learn the malaria life cycle and how this single organism changes and morphs and becomes alien to mosquitoes and humans and birds and lizards. It's just a fascinating life cycle. And it was with that and learning the life cycle of malaria, the incredible burden of disease that malaria causes throughout the world. It causes from 500,000 to over 1 million deaths a year, depending on how well the prevention efforts are underway. And most of those deaths are in children under the age of 5. And we don't have a good effective vaccine yet against malaria. I predict we will have a very good vaccine against COVID before malaria. So we'll keep trying. We also work on tuberculosis vaccines, which is also a major public health priority. Kenneth, what makes COVID-19 so much more dangerous in symptoms compared to the annual flu? That's also a great question. It really has to do with more our immune response to that virus than the virus attacking our cells. And I'd highly recommend perusing some of the articles on the New England Journal of Medicine. They're all available, they're all for free. And there's some fascinating reviews about how the immune system is responding to this virus and resulting in these clotting disorders. Even when you think about the lack of smell or taste that is a consequence of being infected with this virus, and how that is impacting those very neuronal cells, the neuron cells responsible for taste and smell, highlights how complex and devastating the human response is to this infection. Let's see. Do I think it's possible that another virus like this will occur in the near future? Well, hopefully not in the near future, but it is somewhat of a random event. And just as HIV emerged over 30 years ago from a similar trans-species kind of event, it's very likely that we're going to see different pandemics like this in the future. How long does COVID-19 immunity last after infection? That is a major question we're still trying to answer. And that durability of protection and the potential for reinfection and what the clinical symptoms after reinfection are remain a major question for us. There are other viral infections like dengue virus that don't cause too severe of a clinical disease after the first infection, but after the second infection causes a hemorrhagic fever. So there are other viruses that exist upon which second infection actually cause a worse disease. So we're looking out very carefully for that. Maddie says, because the clinical trials are being done so much faster than normal trials, would you consider the vaccine to be as safe as other vaccines that have been created with normal vaccine trial times? And my answer to that is absolutely yes. We're using the same safety monitoring and assessment of these vaccines that we are under normal circumstances. The main difference here is the tremendous investment, again, from our tax dollars into manufacturing the vaccines, accelerating the development, and scaling up that development so that when one of them shows efficacy, we'll have millions of vials to begin distributing. Do people that are in the vaccine trials have to be exposed to COVID? No, that would be called a challenge study. So we do malaria challenge studies in Seattle where we intentionally infect people with malaria, and we can do that because you can cure malaria with a single pill, treat it, cure it, and they are cured, have no malaria after a couple hours. With this virus, we don't have such a rapid treatment. And so there are people advocating for these challenge studies. But what we're doing and why we need so many people in these large efficacy trials, 30 to 60,000 people, is because half get the vaccine, half get the placebo. And then just by nature of having so many people in the trial, a certain number of people, for example, 100 people will be infected in the placebo group. And if we see something like only 20 or 30 in the vaccine group, this would be a tremendous finding. So that's how these randomized clinical trials are measuring efficacy. Let's see, Jason, we are a very diverse society. Would you think herd is a possible solution? I think it is a possible outcome, and hopefully herd immunity can be accelerated by vaccine-induced immunity. I think the diversity of the society is less relevant. Most people, regardless of their race, ethnicity, respond generally to vaccines the same. There are small proportions of people who typically don't respond to one vaccine or another, but it has much less to do with race, ethnicity, and more to do with their individual genetic variations. Gabriella, what are the leading factors that can negatively affect the amount of time needed to complete the vaccine? So those that are negatively affecting it, well, a major one that causes typical delays is the actual manufacturing of these vaccines and the confirmation that they are truly very safe before we put them into people. And we confirm that all along the steps of manufacturing. So that is a major obstacle that these manufacturers have to overcome. There have been delays in getting some of these vaccine trials started because of the manufacturing product availability. Another factor is, as you may have heard, 2 vaccine studies were stopped because of adverse events that occurred in these studies. And when you enroll 30,000 people, especially when we're trying to target many people who are in the elderly ages, we're going to see adverse events occur in many of these people's lives. Even deaths will occur in these studies. But that doesn't mean that the vaccine was at all associated with these adverse events. But we have to pause, we have to review that very carefully and proceed. Let's see, Kenneth, much like the flu vaccine, do you believe that we will be required to get an annual vaccine for the coronavirus? And that, I think, is a potential consequence if the durability of these vaccines is not very good, or if the coronavirus itself, as previously mentioned, mutates in such a way and the strain becomes highly variable that the vaccines we're developing now are not cross-protective to those future versions of the virus a year or 2 years from now. So that is a possibility. We're optimistic, however, that the spike protein and the elements of the immune response against that spike protein that are elicited by the vaccine are sufficiently protective and conserved that annual vaccines may not be required. But we'll be answering that question within hopefully the next 6 months. Let's see. Ethan, at what point does a vaccine become available to give to the public? That's probably the most common question I've been getting lately, which, of course, when are we going to have a vaccine? When will it be available? And therefore, when will we be able to take off these masks and open up society as we were a year ago? And that is the question of the hour. In large part, it depends on the results of the efficacy trials that have either completed or will be completed, hopefully by the end of the year or by January or February. So we're trying to enroll all of these massive clinical trials in the span of the next few months. One of the major challenges to that, which again, I guess is answering Gabriella's question, is we need volunteers. We have a website called preventcovid.org, and we have over 450,000 people who have volunteered at this website, preventcovid.org. And in that registry of almost 500,000 people, we're collecting contact information and data on occupation and social behavioral activity, pre-existing medical conditions, of course, the demographics of age, etc. And in that, we're able to calculate who may likely be exposed and infected and progress to disease in the next 3 to 6 months, because the endpoints of these efficacy trials is COVID disease. And we need people who then are likely, not because we're going to expose them, but they're likely to be exposed and infected and get disease in the next 3 to 6 months. And we really need more volunteers. Even though we have 500,000, we need more than 1 million more to successfully enroll into these clinical trials. And again, that gets to the point of when will these vaccines be available? They'll be available when they're sufficiently tested to be safe and tested to be effective. And we're hoping that will be by winter, spring of 2021, such that by next summer, everyone who wants one will have received a vaccine. Let's see. Caleb, how do you think flu season will affect the COVID-19 cases? That's a fantastic question. And there's some tremendous data that really demonstrates how effective we have been in all of the masking and social physical distancing that's occurred over the past 6-8 months. We have been incredibly effective around the world in reducing flu this season. And that is both a fantastic achievement and a significant challenge for the flu vaccine community, because what they do to develop a flu vaccine, the flu vaccine that I just received 2 weeks ago, was developed from strains of the flu that they isolated last year. So the flu vaccine that will be deployed a year from now will be collected from the flu that's circulating now. And the big challenge of that is there's very little flu right now, and it's the flattest it's been in decades. I don't even know if on record we've seen so little flu because of the measures that have been put in place to control COVID. I would say, you know, we've still seen, I think it's now over 1 million deaths from COVID worldwide. And if these measures had not put in place this year, that number would be astronomically different. And we would have seen the devastation of this without the measures that have been put in place would have really been very, very tragic. Both of my parents still live in Marquette, but they're 86 years old, are very healthy otherwise, but would be a tremendous risk for severe disease if they get infected. So I think, I hope I wasn't talking too fast, but that was a wrap of the questions from the chat.
Yes, that would conclude this Zoom call. So if you have any final statements or just anything you'd like to say to the people of Marquette or anybody who happens to come across this video, what would you like to say?
Well, I'd say, you know, please be safe, be smart. And it's an incredible time to find really amazing scientific data, scientific evidence, and tremendous information at the newspapers. The New York Times tracking of this pandemic has been, I'm sure, Pulitzer Award-winning quality. The science journals, such as the New England Journal of Medicine, have written eloquently about this pandemic in their editorials and in their perspective pieces that I think are very available to high school students. And I think that hopefully this is stirring a curiosity and an interest in global health and public health generally that will help us in the future to be even better prepared, much better prepared to combat such pandemics in the future. I think there's another question, which is mostly a thank you, and you're very welcome. And it's nice to see some MSHS students interested in this topic.
Would you be willing to maybe meet again in the future or having another interview over Zoom?
Sure, I'd be thrilled. Hopefully we'll have some preliminary efficacy results and signals from these phase 3 trials, and could answer some of these questions with even better precision around better timelines of when vaccines will be available, better precision around the consequences of reinfection and the durability of protection from infection and from vaccination. So I look forward to doing that.
Well, I think you did a fantastic job of answering, considering what's going on right now. So thank you so much again for doing this. We really appreciate it. And I believe we are now going to conclude this interview.
All right. Thanks very much, Gwen. Thank you, Eric, for the invitation.